Good evening and welcome to episode 11 of the Hope for Healing video podcast. I'm Dr. John Stracks and I am joining you from my office here in Chicago. And this evening I am here with a colleague and a friend of mine from New York City, Dr. Eric Sherman, one of the most experienced mind-body medicine therapists in the entire world. Before I introduce Eric, let me tell you a little bit about Hope for Healing. Hope for Healing is a joint effort between the Curable app and me. And I know most of you are familiar with both of us, but for those of you who don't know one or the other, I'm a physician with a mind-body medicine practice in Chicago, focused on the reduction and elimination of physical symptoms using mind-body medicine methods. Curable is an amazing app focused on the same goal. We've been working together ever since their inception about 5 years ago. And we started this series at the beginning of the COVID-19 epidemic as we both thought about what we can do that would help support people through a difficult time. So before we get started, I want to go over just a few items. First of all, Eric and I will be discussing mind-body medicine for probably about 60 minutes, and then we'll spend some time taking questions at the end. Our friends at Curable will collate those questions for us and deliver us to them during the question and answer. If you are watching with us on Zoom, go ahead and type your questions at any point into the Q&A chat box. And if you're watching on Facebook, go ahead and post your questions into the chat. Either way, they will get to us at the end. And secondly, and we'll talk about this later as well, I've been able to expand my telehealth practice during the COVID-19 time. And so I am now available to consult with you no matter where you are. If you are stuck with your symptoms and you are looking to reach out to me to find out a little bit more about what to do, go ahead and contact our office at www.drstracks.com, and my staff will give you all the information that you need in order to set up a consultation. And then lastly, just talking for a minute about terminology. Most of you know what we're talking about is mind-body medicine, which to me means that our body can express for us what doesn't get expressed in other ways. That's universal. I don't think that's bad. I don't think that's wrong. I think it's part of the human condition, and we've been doing it forever. It only becomes a problem when we enter into a medical system that assumes that all symptoms are physically based. And we're here to try to help you understand that at times physical symptoms have non-physical origins. Both Eric and I learned about this concept from a physician in New York named Dr. John Sarno, who many of you have probably heard of as well. He was a physiatrist in New York, started his practice in the 1960s, really understood this connection between mind, body well, and was one of the first people to popularize the concept. He called it tension myositis syndrome, or TMS, which is a term that both Eric and I have used for years. Given that these days we have a much better understanding of the whole concept, we generally use terms like mind-body medicine or psychophysiological disorder, but occasionally you'll hear us slip and use the term TMS. So please know that no matter what we call it, we're referring to this concept, that what happens in our lives shows up in our bodies, and that doesn't make us bad or sick. It really just makes us human. Also, since Eric and I both learned a substantial amount from Dr. Sarno at one point, we are going to spend a few minutes at the beginning talking about him and his legacy. I and Eric also understand that there's some controversy about Dr. Sarno's work at this point, but since we personally feel like we learned so much from him, and since many of you have read his books as well, we do want to spend a few minutes talking about the work and how his theories applied back then and have evolved over the years. So that's how we'll get started. With that, let me introduce Dr. Eric Sherman. So Eric is a licensed psychologist practicing in New York City. He received a certificate of specialization in psychoanalysis and psychotherapy from the New York University postdoctoral program in psychotherapy and psychoanalysis. And he completed a clinical internship at the Rusk Institute for Rehabilitative Medicine at New York University. Eric currently has a full-time private practice treating adults in psychoanalysis and individual psychotherapy. He also provides training and consultation to clinicians and other healthcare professionals. He has special expertise in the evaluation and treatment of patients with mind-body medicine disorders, and he's been doing this work now for over 40 years. He treats individuals and families struggling with psychological consequences of disability. He also works with issues around psycho-oncology, dealing with the stress and the psychology of cancer. While on staff at the Rusk Institute, he trained psychology interns in the evaluation and treatment of mind-body medicine disorders. He regularly consults with physicians and other healthcare professionals to figure out how to understand and manage both their own and their patients' psychological reactions to acute and chronic medical conditions, including cancer and disability. He's been one of the leading international voices for the recognition and treatment of mind-body medicine illness and healing. He continues to advocate for better recognition and treatment of these diseases in the mind-body realm over time. Over the years, he's become a close friend and a colleague. We've treated numerous patients together over my 10 years in medical practice, and I try to reach out and see him whenever I get the chance when I'm in New York City. So Eric, thank you so much for being with here tonight, and welcome to Hope for Healing.
Well, thank you for giving me the opportunity to join you on this show. And I want to thank whomever is in the audience for listening. I always welcome anyone who has any level of interest in this subject. So, ready when you are.
All right. Well, I am thrilled that you are here and thrilled to be talking to you in this public forum. Let's start a little bit with the work of Dr. Sarno. Obviously, he was a close colleague of yours for many years, and I studied with him in the late 2000s, early 2010s is when I went out to New York to spend some time with him. What are a few of your memories of your work with him over the years, including maybe how you got started working with him and what you learned from him and remember about him over time?
Well, the way I started working with him was somewhat serendipitous. I was an intern at the Rusk Institute, and in those days we had to do 2 rotations, and they needed a male body on the children's service, and by default I was the only person. And even though I had no training in working with children and no experience, I was impressed into service. And it actually was a very gratifying experience for me. But because I had been a good sport and a team player, I was told I could have whatever choice I wanted for my next rotation. And I picked the pain service, which was headed by Dr. Sarno and Dr. Arlene Feinblatt, who was the psychologist in charge of that service. And she and Dr. Sarno co-developed the basic paradigm for treating TMS or mind-body disorders over 50 years ago. And I had selected that rotation because, well, it was one of the reasons I had wanted to intern at Rusk, because I knew that opportunity existed there. I'd always had an interest in mind-body phenomena, and also that service provided trainees with the most intensive psychotherapy experience. So I was rewarded for being a good team player. It's one of the times in life where, you get rewarded for doing good. That doesn't always happen, as we all know. So that's how I happened to meet him. And he was both charismatic and intimidating. I was immediately impressed with his brilliance. He was very eloquent. Patients revered him. He was very devoted to his patients. He was very generous with the time he spent with them, but he could get kind of impatient with them when they were not getting it, so to speak, even after he made multiple, I must say, he was not someone who lost his patience quickly. It was almost when he was just frustrated that he wasn't able to get through to people, because he had a kind of missionary zeal to spare people needless suffering. And the world we know today is very different from the time I met Dr. Sarno in 1983. And in those days, patients were almost always told, you need surgery, you need surgery, you need surgery. And now I would say largely because of his influence, many patients are told by orthopedists, neurologists, neurosurgeons, physiatrists, that herniated disc is not causing your pain. I don't know what is causing your pain, but surgery will not help you. Unfortunately, these physicians don't usually take the next step and say your pain is a manifestation of a mind-body syndrome. However, it's a hell of a lot better than when patients were told you have a mechanical structural problem, and unless we face it, you're doomed to lifelong pain and disability.
And
So
hundreds of thousands of people have read his books over the years, and thousands of them just by reading his books have gotten better. I think a lot of people who are here tonight may have read his books or heard about him and aren't better yet, which is why we're having this conversation. But it's so easy for a physician to say, I don't think the structural issue is causing the problem. And then, like you said, take the next step. Here, why don't you read about this? Why don't you read one of Dr. Sarno's books? Why don't you download the Curable app and learn a little bit more about the nature of pain? I think, one of the things that you and I have talked about is that, for a long time, it was Dr. Sarno and you and Fran and Arlene and not a whole lot more than that. And now there's hundreds of psychotherapists who are on our email list across the country. There are tens of thousands, if not hundreds of thousands of people who have downloaded Curable. So many more resources in the past 10 years, maybe longer. What do you think Dr. Sarno would have thought about this explosion in the recognition and availability of information about mind-body medicine?
I think it would have been a mixture of delight and almost a kind of aw shucks modesty, because he had over the years many prominent patients who wielded very influential positions in the media, and they would frequently plead with him, please let me start a campaign and I'll do everything. All you have to do is sign, the contract, and I'll have it messengered to your office. And he just wanted to be a doctor, seeing patients. He eschewed publicity. And I think in some ways he inadvertently hurt his own cause, because I think he was a very effective representative of his own ideas, but he was a little publicity shy. So I think he would be kind of in a state of wonderment. And if someone said, it started with you, I think he would have an aw shucks kind of modesty about it.
I would
So,
agree. Yeah, and
yeah.
all the media spots, the 2020 interview, the movie about him, All the Rage that Michael Galinsky did. There are so many opportunities that he had to um, for people to get to know him and get to know his work. And I, for one, feel honored to be able to continue to move this forward and bring it to more people.
Yeah, I always have said to people, when I grow up, I want to be like Dr. Sarno because he retained this youthful energy and curiosity about life. I mean, he was essentially, an explorer, a scientist his whole life, fascinated about, he was fascinated with nature and birds, but just people. And he never lost that curiosity. He never became jaded. He was always learning more about it.
Yeah.
Yeah.
And I think that curiosity is what helps us in the field to understand that all
Mhm.
this is about more than just one field. It's not just about medicine. It's not just about psychology. It's about the intersection, and that's where exciting things happen. And so
Mhm.
let's talk a little
Mhm.
bit about the work that you do. And so you had always been interested in this mind-body medicine concept, and you got the opportunity to work with Dr. Sonar early on. And obviously you've been doing this for many, many years now. And so when we think about patients working on mind-body medicine, and so they're using Curable, or they've read Dr. Sarno's book, and they're starting to get stuck and thinking about what to do next, what do you think are some of the advantages in working with somebody like you who's a trained psychotherapist, especially within this field of mind-body medicine?
So the way I compare it is if you have well, I'll give you an example. I was in Hawaii many, many years ago, and I developed an ear infection, and I was on the big island, and I was told that the ENT visits the island the third Thursday of every month, and I had missed him, and I would basically have to wait another month or go to Honolulu to see someone. So I saw a family practice doctor. She was very nice, and she diagnosed my ear infection and gave me drops and antibiotics, and I got better for a few days. And then it recurred with a vengeance, and I saw another doctor, and he tweaked it. And then by the time I returned to New York, I was a mess, and I saw an ENT, and he 1, 2, 3 diagnosed the problem and put me on the appropriate medication because he, ate, slept, and drank this sort of stuff. And what happens very often is that many well trained and well intentioned mental health professionals, if they do not know about TMS or mind body syndromes, they hear someone saying, I think it's stress related, even though the doctor said I have a herniated disc, and they hear the patient denying the facts, resisting the fact that he or she has an injury that is consequential in terms of his or her immediate circumstances and future. And the emphasis on treatment is about getting the patient to accept his or her limitations and mourn his or her losses. Whereas when someone is familiar with mind body disorders, they're able to understand that the goal of treatment, it shifts from mourning your losses and accepting your plight to kind of creating a breadcrumb trail that will help you follow the path from your pain to the emotions that produce the pain in the first place. So you have a completely different approach. And I can't emphasize, this is not because the other types of clinicians are incompetent. They're just poorly, they're just unaware of it. They have no experience.
Yeah, they're unaware and they're locked into, like a lot of physicians, they're locked into this disease model that there's
Mhm.
something wrong. So physicians will say, you know, you have a slip, you know, you have a herniated disc, you have to do physical therapy, you have to do an injection, you have to have surgery, as if like people are sick and need fixing. And I find that a lot of
Mhm.
therapists easily enter into that system where, as you just said, they say, you're sick, you have a disease, like, and they might say as a therapist, like, well, I can't fix this, you have a physical disease, go find somebody
Right.
who's fixed. And in our practice, one of our core values is being able to see people's strengths and pluses. And so we try to approach people not as diseases that need to be fixed, but as outstanding human beings who are expressing their experience in their body. And so we don't have to fix anything. We need to help people be aware of what's going on and then allow for the emotional expression or the other strategies that help them to feel better. But we are really committed to trying to see the strengths and the wholeness in everybody who comes into our office, as I know are you.
Mhm. Mhm. Well, I just want to share a personal experience that I've discussed many times before. So I am now 69, and when I was 8 years old, which was 1959, my mother developed severe incapacitating back pain that basically tyrannized our household. Everything revolved around her pain, the avoidance of pain, and she availed herself of every available treatment that was available at that time: corsets, steroid injections, physical therapy, bed boards. And she was probably 32, 33 at the time, a young woman with two young children. And finally, the doctors were despairing because they didn't know what to do with her. And they admitted her to a joint disease hospital in New York, where the most sophisticated imaging study available at that time was a Milogram, where, for those of you who are not familiar with it, spinal fluid is withdrawn, a dye is introduced, the person is tilted on a table so they can observe the flow of the dye to see if there are obstructions or leaks or other abnormalities. And after the Milogram was completed, the surgeon, and I can't emphasize enough when I say the surgeon, came to my mother and said to her, "Mrs. Sherman, at least 70% of your back pain is caused by your marital strife. And if I were to operate on you, I would help neither your back nor your marriage. So my advice to you is get some help with your marriage. And if you do that, I'm pretty sure it will help your back." And that was in 1959. But I think with the advent of very advanced imaging techniques, and other sociocultural, phenomena, back pain became more medicalized. And interestingly, I used to run a group at Rusk for, we call them TMS patients there. And there was a woman in the group. So this would have been in the late 80s. And this woman was in her late 80s. And she brought in a little pamphlet that she said you could buy at the corner drugstore for a penny. And it said 1 cent on it. And this one was entitled Lumbago, and it said the opening lines were, "It is common knowledge that the muscles of the back are a repository for the everyday stresses and strains of life." So in some ways, Dr. Sarno would say he really rediscovered the ruins of Troy, because this was once common knowledge that had been forgotten, and he rediscovered it.
Yeah,
So,
and thinking about sort of how much different things would be these days if surgeons routinely said, maybe not you need to fix your marriage, but you need to look at what's going on in your life as opposed to maybe looking at what's going on in your back. And so say a patient reaches out to you and comes to see you as a new client. What are the things that you're trying to get and understand from them when you first meet them? How do you approach somebody who walks into your office for the first time?
okay, so the first thing is, I will not schedule an appointment for anyone unless he or she has first been evaluated by a physician with expertise in TMS, like someone like yourself. And if someone tells me in an email or a phone call, I've read the books, I have all the personality characteristics, it's no, no, no. You absolutely must be evaluated by a physician first. It's for your own protection. So they've already cleared that hurdle. And one of the things, I mean, there are multiple questions that are swirling about in my mind, and they're not necessarily like in a checklist at this point, in my career. It's kind of second nature, although everyone is a brand new experience. Um, I want to know who they're there for. Are they there because my wife told me I better go, otherwise she's not going to talk to me? Are they there because they were told they need surgery and they're so scared of that possibility that they're willing to do anything to avoid it, but they really have no understanding of what I could possibly offer them? So I want to kind of get a sense why they're there, and what their understanding of the problem is. And then I want to um, kind of get a sense, when you were talking about looking at someone's strengths, I certainly want to learn in detail the nature of their difficulties, including their physical symptoms, but I also want to know the nature of their resources to cope with those difficulties, because to know the nature of their difficulties without knowing the nature of their resources is useless. It's completely useless. So I want to know that. And then I also I'm thinking in my mind, okay, what are the possible emotions or emotional experiences that cannot be experienced as feelings, and why can't they be experienced as feelings, and why is it necessary for this person to experience them as physical symptoms as opposed to emotions? And along those lines, I'm always curious, why now? Why are they coming for treatment now? Or why did they become symptomatic now? Although I have certainly seen patients who will say, I've been symptomatic for as long as I can remember. But that's not usually the case. Um, I also want to see if how much access the person has to his or her own feelings. If they have, I'm going to call it the fancy shrink term, is reflective self-awareness, but can they make a statement like, I know I overreact to certain things, or there are certain situations where I know I should be angry or pissed off, but I never seem to quite find myself feeling that way. Or I notice that my symptoms are worse at family gatherings. So I want to see if there's what their level of self-awareness is. And then I also want to kind of gauge, there's only so much you can do in a first appointment, but I want to gauge to what extent can they distinguish one feeling from another, and can they put their feelings into words, and also can they tolerate certain feelings? Can they say, that really frightens me, without shutting down or having to distance themselves from it? So I want to gauge basically how they handle feelings, because ultimately mind body syndromes are not about specific feelings as much as they are about how people handle those feelings. Because you can have a mind body syndrome where anger is salient, but you could have one where fear or helplessness or mourning are the more salient feelings. So I want to get a sense of how they handle those feelings and what their awareness is of their own feelings. And one of the ways I do that is I try to take what I call two parallel histories. I want a history of their physical problem, and then a history of what's going on in their life, and to see if there are any points of contact between those two histories, and also to see if the patient recognizes any points of contact, and if the patient does, what his or her reaction is to it. So that's typically what I try to do in an initial consultation.
That's a lot. So
Yes.
let's talk a little bit more about feelings, which I can guarantee you is a sentence I never thought when I was 18 years old that I would ever say.
Right.
But so much of what we see, so Dr. Sarno, for instance, a lot of his writing is about how repressed rage leads to symptoms, and you and I know that that can be the case, but oftentimes there are other factors that are involved. And so, do you think that emotions that don't have another outlet are the primary driver for mind body symptoms, or do you think it's part of what drives it? There are other factors as well.
So I would say that there are multiple pathways. Sometimes they overlap, to from which a mind-body syndrome can develop. The one people are most familiar with is the repressed rage paradigm, where basically a feeling is repressed and it kind of leaches out through the body. And I believe, please don't quote me on this, and if someone is listening and I've misattributed the source and they know the correct source, please correct me. I believe the English psychiatrist Maudsley said, those that cannot vent their tears will find that other organs weep. And that was in the 1800s. So that would be, I guess, an example of the repressed rage paradigm, but it could be repressed dependency needs, it could be repressed feelings of fear, helplessness. Another route is trauma. When people are traumatized, they kind of, the term is dissociate, they separate their emotional experience from their intellectual experience, because if they were to combine both aspects of their experience, they would feel overwhelmed by the experience. And a lot of times, a physical symptom is an expression of the trauma. It kind of plugs the gap that develops when someone dissociates the cognitive from the emotional. And it's kind of like if someone doesn't speak English, it will not help if you speak to that person in English in a progressively louder voice. They will not get it. You have to switch to their language. And if you're dealing with someone whose symptoms result from trauma, telling them they're repressing their rage will get you nowhere fast. You will enrage the patient, and I guess it could be profitable to see how the patient handles the rage, but that's not the direction you should be going in. Another issue is, again, the fancy shrink term is alexithymia. It's related to dyslexia. I mean, semantically, it's related to, and it means the inability to recognize feelings and put them into words. So for many people, in fact, many people who are well educated and quite intelligent, and they have no cognitive or linguistic deficits, they cannot identify their feelings and put them into words or distinguish them from one another. So in this case, they have no choice but to default to body language, because they don't really have the language of words. And here, if you make the incorrect diagnosis and say it's repressed rage, it's just really repressed, you're going to get nowhere, because you need to, in a way, teach them a vocabulary, much the same way that I'll use the word mothers, but I can actually say any caretaker with an infant first reads the infant's body language. Oh, you're hungry. Oh, you're wet, you're uncomfortable. And when they talk to the baby, they're giving the baby words where they start to link the baby's physical state with a positive emotional state. So again, that's now, will you find people who have alexithymia and are repressing? Yes, of course. But these are, I would say, the principal pathways that people will often develop mind-body disorders.
And there's so many important reasons that people have alexithymia or have difficulty expressing emotions. A lot of people grow up in families where emotions aren't really safe, or where only one person's allowed to have emotions and nobody else is, or some people are allowed to have certain emotions and not other ones. And we get a lot of praise for how well we think and how sound our logic is. What I say frequently to people is that very few people are ever told when they're growing up, thank you for throwing that temper tantrum. It gives me, as your parent, such a great sense of how angry you are in this moment. Like that's just
Right.
not the words that we use. And so I think you're right that a lot of people, without really being able to explain their emotional experience in that way, their body will speak it for them. And so if
Hmm.
somebody's in your office and they don't have very strong emotional vocabulary, or they have a lot of trouble discriminating emotions, or figuring out how to label their experience, how do you start to work with them to help them build up that vocabulary and build up that awareness?
So I'm not being facetious when I respond in this manner. My mentor, Arlene, said that with many patients, you want to do the equivalent of showing them those pictures that we may have seen in preschool, where there'll be a smiling face or a frowning face or someone crying, and the teacher will ask, "What's this person feeling?" And someone will say, "Happy, sad, scared." And she said, that's basically the kind of approach you want to take, but you do it in a somewhat more sophisticated manner. So you ask them first, what do you notice you're feeling right now physically? Um, is your jaw clenched? Is your heart beating faster? Do you feel lightheaded? What kind of thoughts are you having? Do you want to say mean things to this person? And then when they're able to provide some kind of nucleus, let's say, of, yeah, my heart is beating fast and I find my fists are clenched and I, want to give that person a piece of my mind, I would label that and say, that's because you're angry. That's how people think and feel when they're angry. And then I would ask them, how does it make you feel about yourself to think that you were angry? Uh, and I mean, I don't want to say the range of answers is limitless, but it's very extensive. Some people are terrified. Oh my God, I can't be angry. That's a terrible thing. Or only crazy people are angry, or only, um, or people who are low lifes are angry, or I'm glad I'm angry. It means I'm tough. And, people aren't going to, get away with anything with me. So I want to help them understand that. And then there are times that people, it's kind of like Eskimos apparently have like 100 words for snow. There are patients that, how do you feel? Angry. How do you feel? Angry. What they often are feeling is they're frightened or they're hurt. And in response to feeling frightened or hurt, because those feelings make them feel weak or vulnerable and out of control, and sometimes it's gendered, they feel it makes them either unmanly or unladylike. Um, I'm angry. And they can learn that sometimes you're angry. I often give them the example of dogs. a lot of times dogs will bark because they're frightened, and that people kind of do the same thing as well. Um, and sometimes it depends on the patient. It's not like formulaic. You have a sense of what the traffic will bear, so to speak. You know, I'll ask a patient, well, how do you think someone might feel in that situation other than you? Or if you heard a story about that happening to someone else, how do you think you might feel if you heard that story? And those are the ways, I mean, basically, it's to try to stimulate a curiosity in them about, why don't I have those feelings? So that's what I would say typically is how I would approach it.
Yeah, I'm a big fan of Lisa Feldman Barrett's book, How Emotions Are Made, which talks a lot about this. And the concept she talks about is emotional granularity. And I think she says when she first met her husband, she said he only had two emotions that he could recognize. It was like excited and hungry. And then, like, as a researcher in emotion, she gradually like encouraged him to get more words for his feelings over time. And so like Yale University for the Study of Emotional Intelligence has an app, the Mood Meter, that's got 100 different feeling words. And people can look at it and start to pick out like, oh, I think I feel kind of calm in this moment. I didn't even realize that was a feeling and an emotion. And so I love the idea of just introducing people to these words and concepts and helping people understand that they can get a lot of clues from how they feel physically about how they're feeling emotionally, and then starting to recognize like what a feeling feels like both in themselves and in other people.
Right. But again, fortunately for your patients, you have this understanding that um, this inability to recognize feelings or to put them into words or to differentiate them from one another is not the same thing as repressed rage. And, you know, you're fortunately not a one-trick pony, and that's a problem. A lot of people are one-trick ponies, or they don't know what they don't know. And so that's something, you know, I, along with several of my colleagues, especially Fran Anderson, we've been trying to train people to raise their level of awareness about these issues. And even if they don't want to treat such patients, they would recognize it and know this patient needs to be referred to someone who has that particular expertise.
And I also find, and I don't know if this is your experience, that a lot of my colleagues in the psychotherapy world who I really like, they're not always comfortable with emotions either. I see a number of psychotherapists who are very comfortable in talking about people's stories and analyzing it, but it's hard. It's hard for them with their own feelings. It's hard for them with somebody else's feelings. And so when I advise people to seek out the counsel of a psychotherapist, oftentimes I will make that specific recommendation, try to get a sense of how comfortable the therapist is in your emotional world, because that's such an important part of being able to heal the symptoms.
Right, because if the therapist, and look, it's fair, nobody can be equally comfortable with every person and every situation. And that's not a professional failing. What is a problem is if the person doesn't recognize it, because if he or she recognizes it, that person can say, you know, my background is not ideally suited for the kind of treatment you need. Let me refer you to this colleague. And that's fine. You're doing the patient a tremendous service when you recognize your own limitations in a situation, because what happens if the therapist is uncomfortable with his or her own emotions, when the patient starts to express strong emotions, the therapist will inadvertently react the same way as the patient's family did, in ways that are, critical, muzzling, minimizing, devaluing, and you then end up just repeating the situation and entrenching it, when clearly that's not the purpose of treatment.
Right, because we're trying
So
to
yeah,
help, yeah, we're trying to help people understand that emotions are okay. It's a human experience. We have them because we're human beings. And I run into that a lot with my patients who, when we start talking about this, they say things like you said earlier, like, oh, I feel so guilty that I'm angry. And I try to just repeat and repeat and repeat. You're angry because you're a human being, and that's what we do. And emotions are meant to help us both give us information about what's going on around us. Anger is very good at providing clarity and knowing when we need protection. And it's a nice way to explain our internal experience to the people around us. I also, thinking about this too, I heard this visual recently, which I really like in terms of emotions and physical symptoms, which is that, there's this very small area of our brain in Broca's area that's responsible for language and speech. And it's very, very good with language and speech. If I took it out of me, this would be a boring interview. But there are other parts of our brain that are really, really good with emotions, but not very good with speech. And so when we have these feelings, especially if we're not that skilled in figuring out how to transfer the feelings to the language, it's like our brain is trying to figure out how to push, like, from the center of our brain over to the language part, and like it'll show up in our back or as a migraine headache, and it's our emotions are trying to say, you're mad, you're mad, you're mad. And it takes a while for us to figure out, like, oh, that's what that is. Let me translate it into words. I'm really angry. And so the symptoms aren't bad. The symptoms aren't a disease. The symptoms are our brain trying to help us process it so we can recognize what it is and know what to do about it.
So John, picking up on your statement, that's why you want to see someone who has expertise in this area, because someone else, a mental health professional, will just hear the complaints about the symptoms as static. What do you expect me to do? I'm a mental health clinician. I'm not an orthopedist. I can't fix your back. What are you wasting my time for and yours? Whereas someone who is familiar with mind-body syndromes will recognize the communicative value of symptoms and not disregard them as, static or interference on the line, but this is communicative. What is it telling me? This is useful information. Let me pay attention and let me teach the patient. Let me enlist the patient's collaboration to respect his or her symptoms as meaningful communications, rather than disparaging them as expressions of his or her weakness or frailty.
Yeah, it's such a rich area, and we get so much
Mhm,
information from our body that's useful for us over
mhm,
time.
mhm.
So we're getting questions coming in that we'll try to get to some of them in just a little bit. I'm sure that a number of those questions coming in are, A, how do I find a therapist who's skilled in mind-body medicine? And then B, if I can't find a therapist who's skilled in mind-body medicine, is there a role for trying to teach a psychotherapist who doesn't know about it enough that they can be helpful? And so first question there would be, how do you find somebody? If you're in New York City, right, there are a number of you. Assuming that most of our listeners are not in New York, do you know of any strategies to try to find people who have these skills that we're talking about?
So I will tell you what I do all the time, and it's become more frequent with the pandemic. People will reach out to me, and before the pandemic, I almost always insisted on meeting people in person in my office. And then after evaluating them, if I thought, remote or virtual treatment would work, I would continue the treatment that way. Obviously, that's not an option now, but I would reach out to someone who is recognized as having expertise in this area. And generally, those people, I'm speaking for myself, but my colleagues would do this as well, would try to help locate resources for you in your area. It's less of a problem now, actually, with the pandemic, because so many people are using telehealth that actual, geography doesn't make much of a difference, whether it's being evaluated, as you said earlier. A patient from Kansas can now have a telehealth consultation with you, and a patient from Kansas can begin treatment with me. But assuming someone would prefer to start with someone closer to his or her home in the hope that when the pandemic is over, if they still needed to continue the treatment, they could do it, I would suggest that they contact people who are known to be expert in the field, reach out to them and ask them for help in finding referrals in their area. That
And
would be.
and then the second question that I am anticipating that people are having, if just for whatever reason they live in a place where it's not available, they need to use their insurance, there's nobody in their insurance network. Do you think, and you may not know this since you've always been interested in mind-body medicine, but for therapists who are more psychologically inclined and don't necessarily know that they have a role in treating the physical body, do you think there's ways that patients can help the therapist understand so that the therapist can then help the patient?
So I would say yes, but I would say a lot of it would depend on the therapist's receptivity. Uh, People have different personalities, and some people would say, look, I don't know that stuff. I know what I know, and I know it well. And if that's not what you need to find someone else. And then there are other people that would say, this sounds intriguing. So, assuming you have someone who's receptive, you might, um, the patient might suggest that the therapist listen to one of your podcasts or read one of the books by any of the people who have written about TMS or mind body syndromes. Or the therapist might want to reach out to a clinician who has more expertise in the field and gain some, we call it in my field, supervision um, from that therapist for a few sessions to kind of ground him or her or orient him or, point the way and then saying, you run into trouble, you know how to reach me. So those are all options. I find the most gentle way is to education always, I think, is the best place to start. And, you know, listening to your podcast, reading books, articles, those are things. If the therapist is willing to do that, on his or her own time. And
Yeah.
again, yeah.
Yeah, and I've I've definitely had those conversations with patients who are living in places where they don't have access. Here's one of Dr. Sarno's books. Can you take a look at it just so you see what I'm working on? And I think,
Right.
we're as health professionals, we're intimidating to people, right? I'm a doctor, you're a doctor, and so people come in to talk with clinicians, and oftentimes we're afraid to speak up. I mean, me in the patient role is the same way, but it's totally within people's rights to say, like, here's what I'm looking for. Can you get on board with this concept with me? And if you can't, right, if you don't believe that there's any role for psychology in the treatment of physical issues, I'd appreciate knowing that, because I don't want to waste your time. I don't want you to waste my time. But I think that good clinicians are oftentimes very receptive to
Mhm.
what people are looking for. And so it's one of the questions that I ask frequently when I see somebody for the first time, some version of like, if I had a magic wand, I don't have a magic wand, but if I had a magic wand and I could just fix it for you, like, what would we do? What are you looking for? And I think it's totally appropriate to speak up and say, like, these are a couple of things that I need. Do you think that you can provide these for me?
In fact, it's not only appropriate to speak up, speaking personally, but I know my views are widely shared by other professionals whom I have great respect for. We are not telepathic. We might be very well trained and highly experienced, but to date, none of us have become telepathic, and we need input from you. So you're actually helping us by being straightforward and candid. And when you help us, we're in a better position to be helpful to you.
Yeah, absolutely. And so I know the questions are coming in fast, and I want to make sure we can get to at least some
Okay.
of them. But I have a couple questions for you before we do,
Okay.
which is, so one of the questions I get asked frequently, and I'm going to ask this, I think, in two different ways. But a lot of people will get in touch with me and say they've been working and working and working and working on this for weeks or months or years sometimes, and they're not seeing the progress, they're not seeing a reduction in symptoms. And so, both for people in general who feel like they're in that case, and maybe even more specifically, when you're working with a client who's stuck, what are some of the things that you look for and think about to help get people unstuck?
Okay. So, first of all, I always try to inoculate patients with this information early on in treatment, which is it's very rare that treatment will proceed in a linear fashion. It's usually two steps forward, one step back, another step back, staying in place, a step forward, three steps forward, a step back. And I quote a patient who said, in treatment, you learn things about yourself, and they you open a door and you learn things about yourself, but you get freaked out by what you learn. So you let go of the door and the door slams shut on your hand. So now you're freaked out and your hand hurts. But I tell them that this is temporary and this is part of the healing process. And sometimes what seems like a plateau is the patient consolidating what he or she has learned and preparation to take the next move. Sometimes I think of being, so people need to know there are these normal ebbs and flows, and you need to make a distinction. Is this a normal ebb and flow versus, no, this is a period of stagnation. The other is, I'd want to know, is there something that might be making them particularly anxious, that they're kind of, digging their heels into the ground? And it might be a lot of times people are afraid of progress. It sounds counterintuitive, but a lot of times, if they improve in certain ways, it might be a threat to certain relationships that have been very important to them over the years. And rather than jeopardize those relationships, they would rather bring a halt to their progress. So that's something I consider. I'm not saying that's the case all the time, but it's something I think about. Um, and the other thing is, sometimes people are just scared about taking the next step, even if there wouldn't be a consequence in terms of their relationships. Change is scary. So I want to explore that. Sometimes people are afraid to leave a treatment that has benefited them, and they're afraid to, leave the nest. And that's sometimes an issue. So I would, by the way, I'd make a distinction between a period of stagnation versus uh, increased symptoms or new symptoms. Whenever that happens, the first step is to be reevaluated by the physician. But a lot of times, and then a question Dr. Sarno uh, taught me to ask this question is, okay, let's say we completely took your pain off the table and you were convinced that it wasn't just a good day or a fluke, but you were really better. What would be concerning you? And often, not always, but a lot of times, that gives insight into what might be behind the pain or the person holding on to the pain. So those are some approaches that, again, I don't have a checklist. It depends on the patient, but those are the kinds of ideas that I consider when I encounter that.
You and I talked the other day, and I told you that I'm using some of my found COVID time to study more psychotherapy. And I've done some training in various types of psychotherapy over the years. And so this current school that I'm working with, they do talk a lot about the resistance to improvement
Mm-hmm.
in terms of, what are the symptoms, whether it's mental health symptoms in their language, physical health symptoms in your and my language, but what's it providing that can't get provided in other ways? And so the two
Mm-hmm.
questions I've been asking a lot of lately are, what do the symptoms provide that you can't get if symptoms weren't there? And that's akin to the Dr. Sarno question. And then the other one that I really, really like is, what do the symptoms show us about you that's fantastic? And it
Mm.
really leads to some interesting conversations about people's strengths, about people's desires, about the way people see themselves. That's awesome. And we can take, for instance, if we're dealing with, on a more psychological way, dealing with anger. Anger shows a lot about your ability to stand up for yourself. It shows a lot about your ability to know right from wrong. It shows a lot about your desire to protect the people around you. And so really looking at it from 180 degree, because so many people get so embarrassed by their symptoms and frustrated that they're still there. And if we can start to unearth how it points to people's greatness, somehow paradoxically, it's easier to start to give it up at that point. It's like it just wants to be acknowledged for the great work that it's been doing.
Mm-hmm.
And once it's
Mm-hmm.
acknowledged, it says like, okay, good, my work here is done. And so those are questions I've been asking a lot of people lately.
That's a great idea. I have not been explicitly guided by that, but that is a great. That's going to be added now to my, repertoire. Thank you. That's a
Yeah.
good one.
And so, so I think my last question for you for now, I get this question from people a lot. Do people need to resolve all their psychological issues in order to get physically better? And so I think a lot of people feel like if they're not getting better, it means they need to keep working on something. Other people think that the recognition of the mind-body process should be enough. And so what do you say when people ask you that? Like, do I need to finish my psychological treatment before my symptoms go away?
Okay. So for some people, recognition of the mind body process suffices. However, for a not small number of people, that does not suffice. It's kind of like people can be very aware of their feelings, but they cannot tolerate them. So someone can say, I'm very resentful about the demands my aged parent places upon me, and I feel guilty and ashamed and undeserving. And the problem is not that they haven't yet unearthed something that is still repressed. It's that they cannot tolerate that feeling. And by tolerate the feeling, I don't mean you get rid of it, you airbrush it. It means you can have that feeling without experiencing a loss of self-esteem. So when people can privately and internally experience these feelings without a loss of self-esteem, we call that tolerating the feeling. And for some people, that's the last 10 yards of the treatment. I would say no one ever resolves everything completely because we're always works in progress. But the goal of treatment is to help the person develop other ways of handling those feelings other than developing physical symptoms. And the other thing to recognize is life is very hard, and that you're going to have negative emotional experiences just because life is hard. And that doesn't mean you're a failure or you haven't done your work. It means thank God your nervous system is intact and you're responding appropriately by understanding that life is hard. And sometimes that even means transient physical symptoms. Someone's going to have a big exam. They might have nausea or a pain in the pit of their stomach. But if it resolves after the exam, I would not say, oh, you still have TMS, you got more work to do.
Mhm. Absolutely, yeah.
Yeah.
And I think that, yes, I think that symptoms will go away at different rates. Everybody's got their own
Right.
healing cadence. And yes, people start to, if they're not getting better, start to blame themselves, like I'm a failure at healing. And that's the time when we really need more compassion towards ourselves
Mm-hmm.
and continue on with the journey. So let's take a few questions from the audience. I know there are a lot of questions that have come in, and we're going to try to stop by the top of the hour. So we'll get to some of these and not to others. Here's one. How do you reconcile ME, which is actually chronic fatigue syndrome, and mind-body disease? Research points to it having an organic cause, and maybe we're seeing some of the same things in the COVID long haulers. Do you have any experience treating people with, say, fibromyalgia or chronic fatigue especially, and seeing them respond in a mind-body way?
I have limited experience with chronic fatigue. I have much more extensive experience with fibromyalgia, and I would say there have been 2 or 3 patients that who were diagnosed as suffering from chronic fatigue syndrome and who improved very significantly during the course of treatment. And after they ended the treatment, they maintained their improvement, and even in one instance built upon it. Now, I am not a physician, I am not a medical researcher, but you don't know if the findings are correlates or causes or effects. And that always muddies a lot of the understanding of research. Dr. Sarno always said, you can always find a precipitating cause. The question is that really what's going on, with the patient? And I'm sure, and that's the problem with imaging, if you get an MRI with really great resolution, you will always find some structural abnormality that could possibly explain the person's symptoms. But is that really the cause of the problem? So what I would say is that I think the jury is out and there needs to be a more nuanced understanding, in some ways, by saying, well, the medical research shows this, is kind of like saying, well, you have a herniated disc, so that's why you have pain. The medical findings might be correlates or they might be effects and not necessarily causes. So I'm just saying that's something I would keep in mind. Of course, people shouldn't, follow medical advice. I'm not, I don't practice medicine without a license, but those are my thoughts on the subject.
Yeah, and one story I tell about chronic fatigue fairly regularly is one of my patients with chronic fatigue came into my office one day. I'd known her for years, and I said, "How are you?" And she said, "I'm really good." I was like, "I've never heard you say that before. What's going on?" She said, "I stopped talking to my mother." And so there was this boundary that she decided to draw that freed up all this energy that she was using to manage that relationship. And so, like, clearly that's not the issue with everybody with chronic
Right.
fatigue, but I say, I say regularly, I think symptoms, I do put fatigue as potentially in the same category as pain issues.
Absolutely.
All symptoms have a physical component, a psychological component, and an emotional component. And we oftentimes don't know ahead of time how much is in each camp. And so when people are uncertain, I say, well, let's assume that at least some of this is related to what's going on in our mind and in our heart, and let's start working in that direction. And so I have a patient who I'd interviewed on this podcast before, Jill Rydell, who had 200 migraines a year for decades. And she came to me and she had learned about mind-body medicine. It was intriguing. And she said, "I want to be 20% better. I wanted to go from 200 to 160 migraines a year." And so now she has 4 per year. She got 98% better, but she didn't know ahead of time how much better she was going to get. She started to work down that pathway and then found that she could improve so much more than she ever imagined. And so speaking sort of along these lines, somebody asked, what do you do to help people understand the TMS diagnosis? A lot of people, for a variety of reasons, will be uncertain, fear that they're missing something. What do you do to help people get more comfortable with this idea that the pain isn't just a physical manifestation?
Well, what I try to do is point out to them all the normal everyday manifestations of TMS, how people will get headaches before a job interview or stomach aches or what have you, and that TMS is that process just taken to the next level. So it's not that TMS or mind body syndrome is something alien or something that you haven't had many experiences with already. Um, so I, that's the first way I try to introduce them to the concept. And I'll often ask people if they've noticed themselves any fluctuation in their condition related to stress. Some people will say no, others clearly will. And the other is, it's trickier when a doctor says, I'm really concerned about that herniation and if you're in danger of becoming paralyzed. But when people say, oh, it's a herniation, lots of people have them, I would say, look, you've been to several, I mean, by the time someone sees me, they've usually seen between 6 and 8 physicians. And I point out that although anything is possible, you've been screened pretty extensively. So if something were to materialize, it would have to be something that just developed since your last evaluation. And that wouldn't explain a 3-year history of a problem. So I try to do that, but basically I emphasize the normalcy of mind-body symptoms and their ubiquitous nature, and also say, look, let's just try it. I'm not asking you to believe. I'm not asking you to disbelieve. I'm just asking you to be open to the possibility that your emotions might have an effect on your symptoms. And if you're willing to be open to exploring that potential link, then we can do something.
I've also been again, sort of trying to unearth the resistance in people. What are the advantages of thinking about it as a physical
Mhm.
disorder as opposed to a non-physical disorder? The more explicit we make that, sometimes the easier it is to
Yes,
see where the resistance comes
yes.
from. And so, all right, last question for now. And I know there are a lot of questions that that we didn't get answered. And so I just may make you come on again because there are some questions that I didn't
Oh,
get to
I'd
ask
love
you
to.
too. But this is a great question, and a question obviously we get all the time. How are we not saying it's all in your head?
So I will use this example. 10 and 11-year-old boys are very fond of buying plastic poop from novelty stores and leaving it on someone's doorstep. Uh, if someone has diarrhea from tension, I guarantee you what is in the toilet is real stuff. It is not plastic poop. It is not imaginary. And if you really think it's imaginary and all in your head, I welcome you to test it out by whatever means would satisfy your doubts. So that's what I would say. It is not all in your head. Your head is involved in the process, but the stuff in the toilet is real.
Absolutely. And the pain is real no matter
Absolutely.
where it comes from. And what we're saying is that there's a more nuanced formation of pain in our bodies than medical science would have believed, say, from the 1970s up through the 2000s. And I am all for pain relief for people, and I'm agnostic about how they get there. I
Right.
do this work because it is so important and so helpful, and oftentimes in a place that an orthopedic surgeon can't touch, because the surgeons aren't trained these days to say, hey, tell me about what's going on in your life. They tend to concentrate only on what's going on in your spine, and that oftentimes is not the whole story by any means.
Mhm.
So anyway, so we will wrap up there for this evening. And I was serious about trying to get you back on, so you and I will talk about that later on. But thanks so much for being here. And if people are interested in contacting you, is there a mechanism by which they can do that?
Yes, they can go to the website I have with Fran and Anderson for our book. It's www.pathwaystopainrelief.com. And they can read about our work, they can read about me, they can contact me. There are resources on there. So that's probably the easiest and best way to contact me.
Pathwaystopainrelief.com, and you and your
Yes,
partner, Fran
yes,
Anderson, and
yes.
Dr. Eric Sherman. And so thank you. People are so appreciative of your insight and experience. I also want to say thank you to everybody who's been listening and asking such insightful questions. Every time we record one of these, I remind myself how blessed I am to be part of this community and part of people who are working on this in such a nuanced, brave, and important way. As I said earlier, I am available during this time and hopefully longer for people to consult with me no matter where you are. So you can go to my website, www.drstracks.com, and my staff will get back to you with all the details about what a consultation looks like. And if you enjoyed this episode, you can find all our previous episodes and this recording as of tomorrow at Curable's Hope for Healing webpage, which is curablehealth.com/hope for healing. You can also sign up for our various newsletters there and get updates about next episodes. So I will be back in 4 weeks on Wednesday, November 18th, 4:30 Central Time again, with a patient of mine, Jody, who recovered from decades of pain using mind-body methods in a very, very slow and gradual way. And so those of you who are listening who are frustrated with the progress, Jody's a great example of somebody who worked on this over time and achieved significant success. So Eric, thanks so much. You and I will talk later on this week. And thank you for being here and sharing your insights. Until next time, everybody, have a great rest of your week, and please continue to be healthy and safe.
Thank you for having me. Okay.
Thank you for being
Bye.
here.
Okay.
Have
Bye.
a good night. Bye.
Bye.